Welcome, everybody, and thank you for coming. I'm Bill Bond, and I'm at OSF Healthcare and the University of Illinois College of Medicine at Peoria. And we'll introduce my colleagues in a moment here. We're here to talk about a topic that really has come to light for me and really the rest of the panel, and I'm sure all of you feel it too, about the quality of death that patients experience when we know that death is imminent in the next 6 to 24 hours, something that we really don't do all that well. And what we're going to do here today is hopefully going to be a little bit interactive, because we want to talk about some of these challenges in the deaths of both from the patient, family, and the care team perspective, and explore some approaches to the management of these selected cases that we brought today, and share. There isn't a lot of great published evidence out there, because this is a relatively new topic in terms of research, so we can share some of the best practices that we've explored through reaching out to colleagues around the country and finding out from them. I'm going to have the panel introduce themselves, and then I'll work through some of what we were hoping to do. We may have to sort of ad-lib here. So this is the panel, and I will have Paul, if you want to start.
Did you introduce yourself?
I did briefly, yes.
Great. So I'm Paul DeSandre. I'm the Chief of Palliative Care at Grady Memorial Hospital in Atlanta, Associate Professor of Emergency Medicine, and the Program Director for the Hospice and Palliative Medicine Fellowship Program.
I'm Maureen Gang. I'm Vice Chair of Quality and Safety for the Emergency Department at Rutgers. I have a interest in palliative care. I'm not trained, but I do see so much of this in the emergency department and realize that the quality of care that we give our patients is really predicated on their goals and preferences, and that's why I think palliative is so important.
My name's Helen Kurczynski. I'm the chaplain and manager of chaplaincy services at University Hospital in Newark, New Jersey. Get to work with Maureen every day. I obviously work with a lot of patients and families who are actively dying, and I strongly believe that we can make that experience a sacred and healing experience, no matter the environment, for both patients, families, and our staff.
None of the speakers has anything to disclose relevant to this topic. I am going to talk briefly. We're going to flash up, if I can get it to flash up, something called Mentimeter. It's an audience response system. The problem is it is not interfacing and playing well with this computer here. If there is a moment to fix it, I'll try and fix it. If not, the answers that you text in will come up on this computer here, and I can sort of read through them. That was the initial idea, and so we'll play it through that way. So with that, I was going to part of our inspiration for this was the multifaceted nature of this topic, and with that I was going to hand it over to Helen for the next piece.
Thank you. So, do you want me to, we'll stay sitting.
Okay.
Yeah. The main thing for us to think about when we're approaching our families in the emergency department is that everyone has a different perspective. As the movie Rashomon demonstrates, and is later demonstrated in TV shows like The Affair and This Is Us, perspective is very changeable. And so often we cannot change the way that someone is perceiving us, but we can remember that. And one of the things that we can do is to set a good intention in the way in which we engage when we go forward. So rather than try to control what people think of us, we can just set that good intention and then allow, perhaps with the next slide if we can, allow the rest of the team that is there to support us to offer their perspectives to help us get a better perspective of what is going on and all the different permutations of all the different views. And we have our wonderful MASH, Father Mulcahy, the wonderful chaplain, who is one person that you might turn to in these kinds of situations. Obviously case management, palliative care teams, social workers, the nursing team, environmental, can all be very useful assets.
Great. So I was going to walk through the technology. Please ignore the code that's written there. If our med student helper, if you could, with a marker, put a different code up on the paper over there so people can read it. So if you open your phone with a web browser and you go to menti, menti.com, and I'm going to give the med student the code here, which is 98, and then 12, and then 28. And that is the code to get into this audience response system. So apparently when you reboot it, it gives you a new code. You learn something every day. So this is, and hopefully we'll be able to get this to work a bit for us, although we're going to be doing a bit of a workaround here, I have a feeling. So let's see if this will work for us. How do you know when someone is dying? I should be able to see this come up on this computer here. I don't think it's going to work the slick way it's supposed to and come up here because we're having some interface issues with the program. So it came up here, temp spike. Okay. Agonal breathing came up. Natural history of disease, unstable vital signs. Now they're really coming in, okay. Sometimes they tell you, yes, death rattle. So it's a shame that we're not seeing this scroll up here. What's happening for me, if you guys can appreciate, is all your answers that you're texting in or scrolling in for me. This is a fun way to get the introverts in the crowd engaged in the process of an audience response. So we have impending sense of doom. Bradycardia, and there's always a comedian in the group too. I have found from using this with the residents back at my place. So death rattle, definitely, okay. So great. So Paul, did you want to comment? I think. Yeah,
I think there's many things that we all notice when we're considering doing critical interventions. And basically, that's a dying person that we're going to intervene on. So the question is, can we identify patients who might be dying, who the interventions would not be acceptable to them, or would not be maybe reasonable given the medical scenario that's going before them? So all of these things, I think, are telling us the same things that we see every single day. We're looking at patients who are in shock, who, if we don't intervene, are going to die. And we know what that means. And so I think it's really important as emergency physicians that because we do recognize the signs that somebody's going down, we also can make decisions about how to approach that. And I think we do less of that, and I think there's great opportunity to pay attention to what's happening in front of us and put it into a context.
So we had more of a polling question here. And again, I'm going to have to, there might be, I was just thinking if there's one other way to sort of get this little thing to work here. If I could get to a web browser here, I might be able to sort of work my way around this.
While Bill is doing that, I just wanted to expand a little bit about something that Paul said. So I think we have two types of patients in the emergency department. We have the patients who want aggressive medical management that we know are imminently dying unless we intercede. And then we have the patient who wants aggressive comfort care. And I think that those patients are the more challenging patients for us as emergency medicine physicians. I mean, we're used to saving lives, active, medical management, and taking a step back and realizing that active, aggressive comfort care is still something that is really important and takes an active, and we need to take active roles in that as well, is something that I hope people will come away with from this session and come away with some strategies to make that more acceptable to us as physicians, the rest of the staff that we're working with, and obviously patients and families as well.
So I can show you the poll is starting to show up here on my PC up here. So it looks like up to 7 for less than 4 hours, 3 for less than 8 hours. So I would say it looks like the audience is probably at least on the order of 40 or so. And it looks like of those that have responded so far, we have about 24 that are in the less than 800 hours or under category. So about 25. So, and that's about where I thought the poll would pan out, is that most people would sort of be on the early end of that, at the end of that spectrum. So Paul, do you want to take this, this slide? Okay.
Sorry. So these clues, which really look like somebody in shock, somebody who's going to die, were all things that people pointed out in the Mentimeter poll that we were doing. And I think this project, which is something I think worth paying attention to, and maybe it's available online. This is a fabulous resource, and a lot of really good work went into this. This is the University of Alabama Center for Palliative and Supportive Care. Their Beacon project, which stands for Best Practices for End-of-Life Care and Comfort Care order sets for our nation's veterans, because that's where they were implementing this strategy. But it was a comprehensive strategy to try to come up with quick and protocolized ways to care for people that were going toward end of life. So they have order sets in Epic, the whole thing. It's a wonderful resource, which I would recommend looking at. So I think that this type of a protocolizing of processes and trying to create order sets, like we do order sets for sepsis protocols and everything, this could be the same thing, you know, and I think this could be easily integrated. It does require some buy-in and understanding of how do you understand that this is what you're doing. Once you've figured it out, you know, hopefully we make it as easy as possible. This is just one way to think about that. Thank you. So this is an attempt to kind of look at the important time intervals that we think about in the emergency department. And it's really something that we've come up with and Bill put together. But I think it speaks to a couple of really important time nodes. One being less than 6 hours, because when we're talking about length of stay in the emergency department, it's one of the parameters that we're being held responsible for. It's what people get feedback on this. This is an important thing in the emergency department. It's RVUs are based on your success at seeing multiple patients. Length of stay can be part of your RVU as well. So thinking about if a patient's going to be dying, in your estimation, within the next 6 hours, it's probably going to mean that's somebody you're taking care of and you're going to be managing. Patients who are going beyond that, they still might be dying in the emergency department depending where you work. At Grady, they probably will be dying in the emergency department because we have 80 patients sometimes boarding who may be responsible to the ICU or some other team, but you know, they're right in front of you, and you basically become responsible for the things that are evolving in front of you. So they may or may not be, it may or may not be happening in the ER, and if you have processes to address that, it would make that process a little bit better. This might mean the difference between setting things up to allow for the patient to die in a way that's not going to be overwhelmingly negative to the family's experience or to the patient. You know, there are different programs that have done a few things, and we'll talk about that in a second, to try to address this. So the things about protocolizing, about using order sets, those are part of it. This could also mean, is there a place, is there at least a type of environment where if somebody's going to have to die in the ER, is it done in the best possible way? Does everyone in the ER know that this person's going to die, or how you would manage the situation? Do we have a team of people that are available? Is there a chaplain that's part of this process who can be interfacing? You know, this is as much a team sport as anything else that we do in the emergency department. When somebody's dying, a family's in crisis, the patient has tremendous needs, they're in critical condition, we forget about that. I think when we decide that somebody's dying, we forget that everyone dies in critical condition. You know, and that's an important, I think, take-home point with it. So if they're going to die in the ER, we should have, as best we can, a protocol to make it as smooth as possible and hopefully as algorithmic as possible. If they're going to be likely dying in the next 24 hours, you may have other options. It might mean you have to admit the patient to the hospital. and that it's going to be managed in the hospital. Still would be best if it was handled in a particular way, if there were arrangements with the hospice agency, if you had an inpatient hospice unit. Sometimes that can work out depending on your institution. Sometimes they can be moved out to an inpatient hospice unit, even if they're going to die maybe in the next 6 hours. It depends where that unit is, what you've talked about with the family. You can say, well, okay, I don't see any way out of this. They either are going to be dying in the emergency department, we'll do the best we can, or there's this place that's a mile away, and if we work quickly, we might be able to get them over there so that this could be handled better. But there's a risk that things might decompensate on the way there. Is that still a better idea for you? You know, if somebody's in the ambulance with them, that kind of thing. And it's a variable response. It's not always no. Sometimes it's, I'd rather just get them out of here, even if they die on the way. And it's not likely, you're not going to let somebody go who's obviously in the throes of dying. That has to be discussed ahead of time, but you know, it's more about a shared decision-making process with the family when you're trying to make that kind of a critical decision. But inpatient hospice units, if they're available, if the hospice agency has a relationship with your emergency department, if you have more than one option, can they come 24/7, or is this a daytime only kind of thing? A lot of places it's just daytime. We have an arrangement with a particular agency where if we get called as a palliative care team from the ER and everything's been worked out, families present, they're available to sign consents, we can get them out. We can get them out of the ER and straight into the inpatient unit, you know, at 2 o'clock in the morning. So, and we don't have to come in. We just call the nurse, they dispatch the nurse on call from the unit, they assess the situation, they call us, we talk about it. If it makes sense, we can get them out. So same thing with a person that's going to be greater than 24 hours. Greater than 24 hours, if things are evolving, maybe the family's not present, maybe there's some confusion, you might actually end up having to admit the patient. But if there is family, or even if it's not the legal next of kin, you can start the conversation about this is probably not going to go well. You know, prepare, these are the next steps, and then maybe even involving your palliative care team if you can.
So this is my case. That was a patient that I had, and I just was asking Maureen if she's being kind enough to write menti.com for those of you who came late regarding the audience response system, and then that's the code for the presentation. I had one of my 11 a.m. to 11 p.m. shifts, and my first patient of the day was a lady who came from our local casino. She was with her extended family on a holiday weekend and had a sudden change in mental status. So she arrives with her 90-year-old husband before the extended family arrives. And she had some lateralizing findings, some more left-sided weakness, and her mental status rapidly deteriorates, and she loses the ability to follow commands. So I was thinking, well, this is either a really big ischemic stroke or more likely a hemorrhagic stroke was really at the top of my mind from what I saw evolving in front of me. We really didn't have any past medical history. Her husband wasn't the best historian because he was also, I think, 89 or 90 and didn't have any records available on arrival. So when she came in, vitals are, as you see them there, saturation is 94% on supplemental oxygen. She did seem to move her right arm initially on command, but this was rapidly lost, and we couldn't tell if this was gaze preference or due to her overall level of consciousness that she wasn't following our gaze instructions. Otherwise, cardiovascular exam was quite good, other than a slight murmur, and otherwise you can see it was okay. So, you know, I explained to the husband, who was the only one there at that point, I believe, that look, I don't feel comfortable with her going to CAT scan without airway protection, and, you know, that we would go ahead and secure the airway. And so we did that uneventfully and got her off to the CT scanner, and of course she had a large hemorrhagic infarct. With that, there was a little bit of further history. So the family arrived. So of course we had kids, grandkids. I think we even had great-grandkids. We had, so she had mild memory deficits, but she was very independent. She actually was doing better in terms of cognitive function than her husband, per the sons and daughters who were there. And just some mild things that you associate with aging. And as you can see, she continued to be active in her church when transportation allowed, and probably got to be 90 by avoiding the cigarettes and drinking occasionally. And then eventually in the room arrived her daughter, the POA, another daughter listed as a secondary POA, and the son, and then 3 granddaughters, 2 grandsons, and there were great-grandkids as well in the waiting room. So pretty nice in terms of being surrounded by your family. The family decided they would like a neurosurgical consult because she had been so healthy and doing so well before. And thankfully our neurosurgical team was willing to come to the bedside and discuss with them. We discussed mannitol, and neurosurgery came by, and they were quite good about explaining and sitting down with the family and explaining that they really were unable to successfully intervene in this large hemorrhagic stroke in her age. And the chaplain arrived also to help support the family shortly after the neurosurgical team. More family members arrived at 3 o'clock in the afternoon, and we had a discussion with the family. And so we'll move to, and again, I have to click the button on this computer here to activate the audience response thing. Hang on one second. So the way this works, again, for those folks who made it in a little bit late, is that you can free text into this question. Sadly, because it's some AV stuff, I'm going to have to read what comes into you, but for what we're seeing up here is all your responses will scroll up in front of us here. So what do you think? What options, goals, and expectations should be discussed with the family? The team here see it as well. So I'll read a couple here as they come up. So, compassionate extubation, okay. That she'll likely decline and never get back to baseline, okay. Extubation versus expectant waiting, okay. And let's see if I can get this RVU to scroll down a bit here. Clarification of the dying process and withdrawal of ventilation support, what that means, right? Neurologic outcome expectations.
Anticipated quality of life limited.
Right, okay. So some great thoughts. So with that, I was going to see thoughts on some of these that are coming up here from our panel.
So, as Bill noted, it's really wonderful that this patient had her entire family, or at least a significant proportion of her family, at her bedside. However, it definitely presents a challenge, I think, to us as care providers, having so many different people with different knowledge of the patient's wishes, her underlying, what's important to her, and being able to make decisions that she would make in her behalf. So trying to manage everyone's expectations at once, I think, is a real challenge. And then what do you actually want to have, who do you actually want to be part of these conversations when you have great-granddaughters and granddaughters? Trying to have a private space to be able to do this, I think, is something that's really, a big challenge in the emergency department when we're dealing with these patients. So I think all of the comments that were made are especially telling for the things that we do on a regular basis and what we try to do when we do have patients in these serious conditions, and we're trying to manage patients' needs and family expectations. So I think maybe Helen, you want to talk a little bit about some of your.
I would just add that although to us, to the team, we might think, well, 91, it's not shocking, is to really take seriously that it is shocking to this family. To really take that seriously and to recognize that they're all arriving completely discombobulated, they're stressed out, they're not expecting this, and to give them an opportunity to kind of settle a little bit first. So let them come in, settle, and talk a little bit about her before she came to the hospital, get to know her, so that as you're maybe, you know, she's a member of the church, and so and other things that she really enjoyed doing, so that you can bring those into the conversation when you do start sitting down with the family, because they've had a chance to settle, you know a little bit more, and that conversation will move more easily.
So if I can just add to that, because I think that's a great point, Helen. These sound from a standard emergency medicine sort of brain, this sounds like, why would I be going into that? And I know this. But this is a really easy way to get right in there and to use the information efficiently to give advice based on this person. And I think that's sometimes overlooked. So if you enter the conversation by saying, I know you've just heard some really bad news, tell me a little about so-and-so, her name. They'll tell it to you in a minute or two. It's not going to take that long. All you want to hear are a couple of key phrases, and they're very common. They're things like very active, very independent, very social, very loving, you know, wanted to always do things for other people, you know, blah, 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 blah. And now you know where you're going with the situation. Because then once they've said that gives you an opportunity to say, well, under these circumstances, that doesn't sound like the kind of person that would do okay with what we're talking about. What are your thoughts? You know, and then you've almost got the decision. That doesn't have to take more than 5 minutes. You know, you could do this quickly. And I think that considering these kinds of unusual questions can really cut to the chase and can help them feel like you actually care about them. You know, where you get resistance is if they don't think you're really in it with them and you're just trying to get things taken care of and move on because, you know, she is 91 years old and I don't know why she's intubated. You know, they know that that's a sort of a scientific script. So I think trying to connect to them on a human level through those types of questions can immediately bring you there, and it can make you more efficient. We don't think that, but I think experientially it is the efficient route.
It also brings the family there more quickly too, because the moment that they talk about all the things that she does, and then they look at her, it's very apparent, and they're immediately right. So sometimes yeah.
I'm going to move us to our next question is, how do we prepare the family for what is coming?
What?
Oh.
You were talking about perspectives earlier, and how everyone has a certain perspective of their loved one or friend that comes in. I find that there's different patients that come in this situation, whether old or young. It's like those who were otherwise healthy, 90-year-old playing tennis the day before, or like they're in and out of the hospital every other week or every other month. And I feel like the conversation is very different depending on which type of patient you have. Like this one seems like a shocker. And I find it very, I'd like to believe that it takes 5 minutes, but I think it takes much longer just given the kind of family discussions we have when we rotate in ICUs, for example. Like I feel like it takes much longer to have that real intimate type of conversation, because it ultimately ends up becoming like, well, let's just, for these shoppers, like, let's just wait and see. And I feel like in the emergency conversation, we can't worry about how busy you are. It can be very
You're right, but I think an important thing that what you said was you're talking more about the ICU. And the goal in the emergency department is not to try to begin a debate about where are we. If it's clear that this is a devastating and dying scenario, the question is going to be, do we continue this? And that's all you need to know. Because if they're not there yet and they can't say, you know, well, I'm not sure what we should do or any of that, you've opened the conversation, and then the ICU conversation is going to be a lot easier, whether it happens tomorrow or whatever. You know, it's not optimal, but, you know, it's the best you can do. So it's not that you're always going to resolve it. You're not. But in a situation like this, if they're pretty clear that what the future looks like is nothing that she would have ever wanted, you've got an answer, right?
So we have some answers coming in now for the next question, but for the
Question back to the previous one. How do you mitigate or deal with the situation where you have 2 or 3 family members who are disagreeing with what should be done, and you have no written direction for that patient who can't respond? Because we run into that, and that can get compromising.
yeah, I don't know that there's a quick resolution in that case.
Well, I mean, it's like most of the things that we make decisions about in the emergency department. The default has to be maintain life, and if this is going to be an ongoing debate, you've brought up the questions, and they're going to be admitted to the ICU. That's all you have, right?
Yes, sir.
That was my point. This is eerily similar to a case we had about a month ago when I was teaching. And I said that you would never take 5 minutes. And you will never have consensus with the family. You know, some families will just take a long period of time. And so I think the 5 minutes you can explain, I think, but I think what the family here is much different. It's not really this. There's a lot of people there. It's going to take a long time.
I would clarify, it's not to say that the family meeting will take 5 minutes, but to gain a history of the patient and what their interests are and how they've interacted with their community and with their life. That's the piece that we're talking about here. It's not a 5-minute family meeting. Yeah.
And if it's going to take a long time, you're not going to do it. So if they've already got a clear sense of what the future is going to look like, and you have a clear sense of what the future is going to look like, and they're already clear that they would never want to live like that, you probably already have an answer. And so if you don't have an answer, you're not going to resolve it. I have, okay.
In some family, in some community members may have it, but I would submit to you that it's really unanimous. And so I don't think you have it.
Yeah. Families are different, and some are unanimous, and so that's kind of the goal. You have to figure it out.
Yeah, I'm going to take one more, and then we're going to try and jump to some of the ones who texted them in. I just want to...
In perspective of time, being that we're a university department, we have 1,020 years of patients. If you start the conversation, have the families speak amongst themselves and then walk away and come back as you go see other people, I think that's probably maybe best to just let them speak amongst themselves.
Yeah.
You see other patients, and then you kind of just speak in and
Absolutely.
say, have you guys got a plan? Is there anything that you do? Do you need more help? Do you have questions now? So I think
And
And that often has to be the approach you take. You give them the information, give them some time, come back. We do this with other situations all the time, right? We're going to have to do something. You're going to have to think about whether or not you're going to allow us to do this. Even if it's like a spinal tap, you've told them you need to do it, and they're thinking, I don't know if I want you to do that, but you've given them the reasons. You're going to give them some time. You're not going to sit there while they're trying to figure it out, right? So it's similar, I think. That's a great point.
And that's why having a team around you is so important, because you've got all these other perspectives. So yes, you can walk away, and when you see the case manager or the chaplain or someone come into the, quickly give them a heads up, so you help empower them when they walk into the room. They kind of know what you're trying to find out, and maybe they're going to make some headway and be able to come so you can come back together to get an answer. But yeah, definitely.
Right, if the chaplain's there listening to that conversation ongoing, they can update you. So I think a great strategy. A couple things that came in here. Explain what we can expect the course to be and what we can do to make it better and make them comfortable. Absolutely, great answer. Be honest with them about their prognosis for their family member. Find out what worries them and tailor the conversations to that. Yeah, well said. Empower the family to aid in the care of the patient, such as recognizing the need for additional analgesia. Right, that's giving them some control, which is a basic human need, right, to have a little bit of control in the situation. Can you help keep us informed as you feel like that he or she is having any discomfort? Very, very good. Absolutely. So some nice answers that came in that way as well. So I'm going to right arrow that one. So back to a little bit of wrap up the case, and then a bit of sort of tailored protocol, because again, some of this is sort of thinking through how do we get the best practices out there into our emergency departments. So the family decides they'd like to proceed with extubation. The nursing staff is somewhat uncomfortable as there really is no ED protocol at that point where I am. RT comes down to help with the extubation. Morphine is given to help with the extubation process and presumed pain from the hemorrhage. So as we think about this, there are some great protocols that are out there in the literature, and there's a very nice article here from 2019 from Wang and Kriol-Boulos. I hope I pronounced that correctly, the second one. To sort of think through the actions in comfort care transitions and the different medications that we could use. So this is one of those references we'd like to point you to that just came out. That is a very handy reference published in Journal of Emergency Medicine, and some tips that you may go through to help build protocols in your department to help with this. Because when I was going through this with my team, I very much wanted to say, where is that protocol book or the virtual version thereof that I can reach to that will help guide me through this process? I found myself getting coaching from the RT, and this is how we do this up in the ICU. Okay, it's sort of something that doesn't happen every day for me, and so again, you can go through this as a great reference. We wanted to point you to some of those things that are out there. So the progression of this patient continued to have we had hypertension and bradycardia, as you'd expect from the hemorrhage. Had mostly stable vital signs at about 6 o'clock in the evening with occasional brief respiratory pause. The nursing supervisor starts to get anxious. Like, we never feel this pressure, right? That we have to move the patient through the ER and okay, it's, as we were, there's sort of a Monty Python joke in there somewhere, I think, about the, how long is this going to take? It's sort of, so internal medicine, of course, prefers not to admit, given imminent death. Palliative care is consulted, and this is one of those, as we were building this, my colleagues like Paul shared with me, they often get this very late consultation. And other family members are still sort of wondering, maybe she'll recover, right, because she is still breathing. And then at the very end of my shift, called to the bedside to pronounce death, and so she did pass away peacefully. So a couple of more sort of, again, we're having some conversational things we've been talking about, but now more to sort of the symptom side of things. So what symptoms, and if we could play this, you would see a very cool word cloud that is appearing in front of us. So we have seizures, agitation, gasping, coming up there as things that may come up in the scenario of extubation with brain hemorrhage, yep. Unknown survival length, right? I mean, it's, limited, but we don't know exactly how limited in terms of, is this 6 hours, 8 hours, 24 hours, right? Secretions, yep, secretions. Yep, air hunger, tachypnea. Abnormal movements, right? In addition to seizures, you might see other abnormal movements. If we take the tube out, right, you may have moaning. So, wow. If only I could display my word cloud. My little tech brain is so sad. So with that, I was going to turn it, I think, back to, we have one more. So how do we ensure that the staff have the capacity, both in ability and time, to give the needed care? So this gets at some of those questions of sort of, both local and national policy, I think, really. It's both. So change nursing ratios, a protocol with a specific area and training, yep. Try to give the nurse only low acuity patients in addition to this patient, so being mindful of nurse to patient staffing ratios, right? Admit them to a palliative care floor. Okay, so At my institution, we have comfort beds, so we do have several inpatient beds that are designated as comfort beds for this process. But we don't have a comfort floor, and we're going to talk a little bit later about a nice process from Paterson, New Jersey. Train staff for patients like this, right? So invest in your staff and their training in this particular topic. Assign a resident to that family, so do some workload distribution among the residents, right? Prior training, build protocols ahead of time, build response teams, right? Be ready to mobilize the resources. Try and get the patient out of the ED to a better environment. Ensure nurses are aware of the possible outcomes of post-extubation. Absolutely true, because it's that staff discomfort, not just the family discomfort, right? It's the staff discomfort. And consider an ICU patient with an appropriate ratio. So, and I think, Paul, you were going to do the next couple slides, I believe, Paul. So I'm going to.
So I think we can.
Might pass that.
Maybe we can quickly do the second case,
Okay.
but then I think we need to move quickly to.
We have about 10 minutes to go here.
Yeah. So the next slides are case 2.
Yeah.
So Maureen can do that.
So Maureen can do our case.
You talked about the fact that the medicine team refused to admit the patient.
Right. So I think that is part of the challenge of these cases is that the pressures are, it is the logistics pressure, right? It's the work burden pressure, the logistics, and it's everything from, do I have an EMS person to transport them to the hospice facility if we think this is a 24-hour process? So do I have that person available to transfer them? Does the ICU have a bed? Because if they don't have a bed, right? I mean, I'm sure you hold ICU boarders at Jefferson, right? We hold ICU boarders in Peoria, I can tell you. So it may not matter that you have an ICU request in. They may still wind up going through that process in your ER. So I think it does speak to sort of getting medicine at the table. And we've had pretty good luck because if you get the hospitalists at the table and build the comfort bed process, then they are willing to, I think, a little bit more willing to admit the patient to those comfort beds where a process of care is now designated and understood through various order sets and nursing staffing ratios. When that's in place, you have more buy-in. So
I just want to, comment on that. I think that from a physician perspective, whether or not it's an ED physician or an ICU physician who's taking care of the patient down in the emergency department, I think the real challenge from a staffing perspective is the nursing perspective and the amount of time and care that the nurses have to give to this type of a patient. I think that nurses feel a lot of distress when they are dealing with an actively dying patient in the emergency department. I think that their ability to kind of shift focus as an ED nurse from aggressive comfort care to aggressive symptom management for a medical management of a patient, I think that's very difficult, for them. And I think that what happens is that these patients become a much lower priority for them, and I think that the patients and the families suffer for that. I think that from an emergency department perspective, we have to focus on is getting these patients into a private room, whether or not that be upstairs or in the emergency department, having the family have access to these patients 24/7, no longer have whatever stringent visiting rights you might have had previously. I think that we have to look at that from an emergency, department perspective. I think that, making sure that the rooms are quiet, that we remember to take off monitors for an actively dying patient so that the family is not constantly hearing the monitors go off. I think that that's all something that is in our control in the emergency department, and I don't think that's really so much physician, led, but that's really protocol driven and nursing driven. So, I just wanted to bring that up. Okay, so second case? Okay.
Yeah, I think, and what we may do is jump a little past the Mentimeter slides just so we can get to some of the other concepts.
So this is a patient that Helen was intimately involved with. It was a 59-year-old male who was presenting with respiratory distress. He had been diagnosed 9 months earlier with a motor neuron disease with fasciculations. He had a trach placed, and he had a peg placed, and he had been seen in the neuro clinic 3 days prior to his ED evaluation. At that time, he had reported improvement in weakness from his visit at the neuro clinic 3 months earlier, and now he was currently walking with assistance, and he was using a wheelchair for far distances and was undergoing PT and OT at home. He had no swallowing difficulty, had the PEG, but eats only by mouth. And he had had a tracheostomy in the past, but now is using non-invasive ventilatory support and mechanical insufflation and exsufflation. He presents to the ED 3 days after the neuro appointment with fatigue, respiratory distress for 2 days. He's now somnolent, and his SATs are in the mid-50s. His vitals, he had a blood pressure of 167/101. He was tachycardic, respiratory rate was 24. His SATs were 60% on the home device. He had been non-compliant with his devices at home, and per the white, he had been refusing the trach and no longer wanted to use a home ventilator. And he was placed in the ED on NIV, and he had some improvement with his mental status. Palliative care was consulted, but they were unavailable at that time, but our wonderful chaplain was, and she came to the bedside. The patient did well on non-invasive ventilation, and he blew off his CO2 within an hour, and he became more alert. The wife was requesting that we remove the mask and just let him go. She was afraid that bringing him back, for him only to say, "Let me go again," and so really was not in favor of any more invasive respiratory support. The MD hoped to get the patient to an inpatient bed as quickly as possible. The case was discussed with med consult and bed management. More family arrived. The bed was allegedly supposed to be ready within 30 minutes. The patient's mask was removed. The patient refused morphine for respiratory distress, but he only wanted benzos, and his requests were honored. He said goodbye to his family, and he died within 30 minutes in the ED. So, Helen, you want to comment a little bit about?
Yeah, I think just jump to the pause concept, I think, in the interest of, there's a couple key things I want them to take home, and pause is one of them.
Okay. Okay. So, Helen, talk about...
So the hardest thing for this family was coming to terms with the fact that the patient, he was ready to go. He'd made it clear in his actions and his statements, and the family wasn't ready to, quote unquote, let him go yet. And having conversations with the wife to talk about the way in which, for example, our connections with others are beyond the physical form was something that resonated very deeply with her. And she realized that she was starting to feel guilty for the amount of pain that she believed she was putting him through by trying to keep him there. She used this gesture, I'm trying to keep him, I'm trying to keep him. And once she found some peace in that, she was able to let his wishes come through. And some of the things that we've started to implement within codes within the hospital, hopefully within the ED soon as well, is the pause, the medical pause, where immediately following the death of a patient, we pause. And it can be any member of the team, it doesn't have to be the chaplain, it can be any member of the team can just say, immediately after the time of death has been called, I'd like to take a moment just to reflect upon the life that has transitioned here, and the efforts that have been taken to sustain and support this life, and the love that will live on in the hearts of everyone who knew him. And it can take anything from 30 seconds to a whole minute. It doesn't have to be long, but it allows everyone to drop their, just to pause, to catch their breath. And when the family are included in that, it is remarkably healing. when the family and the staff and the clinicians are included in that, it is really remarkable to see. So people often say, oh, they need more time. They don't need, patients' families don't need more time. They need more skill in helping for them to move on in this transition.
So I think I do want to make sure they hear about the life-sustaining. I think Paul's going to walk us through that.
So, thanks so much for that, Helen. How many people do this routinely, say after a code that's failed?
Wow. Very good.
That's awesome.
Yeah.
Did you?
I'm usually my two. I did this for the first time recently, and this is not routinely done in my emergency.
Yeah.
It's a PQI2, it's a meeting the code, and asked, and I don't know, it just sort of spontaneously happened. And I think every single individual that was a part of that code came up to me at some point during that shift. Okay?
Yeah.
It was profound.
Yeah.
Yeah.
Yeah. There's a lot to be said for sort of the residual moral distress of not attending to these things cumulatively. And by attending to them, it really does help people to move through this. I think Tammy Sherrill would be so proud to have seen the number of people that do this. Cheryl Heron, for those of you who may know her, introduced this to me several years ago, and I saw her do it after one of our codes, and I was like, that was fantastic, and there was like 15 people in the room, but everybody just stopped, and just hung for a second, and it was wonderful. It was really helpful. So I'm glad to see that people are able to do that. I also like the idea of in a death that's anticipated, that there can be an opportunity there, which I hadn't really even thought of myself for something that we could do. So a protocol that's out there that I think is just wonderful and worthy of all of you knowing about, and I think is really a model for best practices, is in Paterson, New Jersey. For those of you who know Mark Rosenberg, he really made this happen. It was kind of an offshoot of their efforts with the geriatric ED effort. And this is a $160,000 a year ED, so it's very busy. But they created a comfort kind of suite in the area around the geriatric ED that they had created. And they have protocols all set up for how to manage a situation where if it's clear that a patient's going to die in the ER, everything is sort of mobilized in a very unified way. So I think that kind of a process, although not the easiest thing to implement, it's all about protocolizing, getting buy-in, making sure everybody understands what they're doing, and all of the team members are part of it. It's not, just one person doing it. Having chaplains that are familiar at all shifts, nurses that understand the protocol who are assigned when this is happening. Those are things that are things to consider. They've done a great job, and it's a beautiful setup. We can't do that where we are. We don't have that room, but we have private rooms. So these are things that can be implemented, I think, probably anywhere where you can get some privacy. It's more just about anticipating it and setting it up with some protocols. So I just wanted to mention it. There is an article that describes that experience, which is referenced here.
I think with that, we'll probably wrap up unless, we had a third case, but we are out of time. We have references at the end of the slide set. I did put up, Kate Aberger was able to give me the protocol for the LMSA, and so that's in doc form, and she said it was fine to share. So that should be up on the website where I initially submitted the slides. And then if there's anything that is missing from the slides that are on that site, feel free to email me. So just to let you know, all the references that we mentioned were there. And this is always good to have. And then I just wanted to see if our contact information, so our emails are there as well. So if you wanted to reach out to any of us, I think it shows the great depth of the topic and the challenges we face, the richness of the questions that came out. Any other questions for the panel before they probably pull me off the stage? Do you want to
It could be both. It could be both. Typically, the pause was designed around codes where the family wasn't present, and over time it's kind of graduated so that sometimes family will be brought in, and now also you can use it in like ED settings, like as we were saying, when a death is anticipated. So why not? I mean, every case is different, and if you've built a rapport with that family member, let them say a few words as well. It can be very healing. Right after the time of death, yeah.
All right. Thank you all for coming.